everyone. So thank you speakers, thank you organizers for giving me this opportunity. The topic given to me is the TDM1 and osimertinib, the TRIOMOS trial, the combination used to target the HER2 bypass tract resistance in EGFR mutated NSCLCs. Now this is the interim analysis of the phase 2 trial. So the background of the study is basically we are all aware that the EGFR TKIs have improved survival in the patients with EGFR mutated non-small cell lung cancers. We've seen the FLAURA data with the overall survival of about 39 months. The problem is over time all these patients develop some form of resistance mechanisms. We've talked about various kinds of resistance mechanisms which could be EGFR dependent or independent. So one of these resistance mechanisms is the HER2 overexpression and amplification. Now the data says that about 13 to 15% of these patients have a HER2 overexpression or amplification. So that is what the whole idea of this study was. So TDM1 is a HER2 antibody drug conjugate and osimertinib is the third generation EGFR TKI. So here we'll discuss the interim analysis of this single-arm trial using the combination in the patients who have progressed on EGFR TKI. So that is the basic hypothesis, the EGFR and HER2 blockade combination with TDM1 and osimertinib to induce tumor responses in patients harboring a HER2 bypass tract resistance mechanisms with manageable toxicities. So coming to the methods, so this was a single-arm multicentric phase 1-2 trial. The patients with advanced EGFR mutated HER2 NSCLCs with HER2 bypass tract activation having a IHC 2+ or more in 10% or more cells or HER2 amplification with diagnosed with ISH or NGS and had progressed on an EGFR TKI. So TDM1 was given as the standard dose of 3.6 mg 3 weekly and osimertinib at 80 mg. So the patients who had progressed on first or second generation TKIs, they were initially put upon osimertinib, and when they progressed on osimertinib, that is the time when TDM1 was introduced in those patients if they had a HER2 positivity. So first a phase 1 safety run-in was done, which was a classical 3+3 design. Initially 3 patients were taken up with the TDM1 dose of 3 mg per kg. In case none of the patients had a dose limiting toxicity, the dose was escalated to the standard 3.6 mg per kg dose. Response assessment was done every 6 weekly based upon the RECIST. Treatment was continued until disease progression or unacceptable toxicity. The sample size was calculated based upon the Simian 2-stage minimax design. The endpoints, the primary endpoint were the overall response rates after 12 weeks and the safety and toxicity. The secondary endpoints were the disease control rate and the PFS. Now coming to the results, so from January 2019 till June 2021, 27 patients were evaluated. These patients were started on TDM1 and none of the patients had a dose limiting toxicity. 2 patients have not been evaluated. The median PFS was just 2.7 months. The median duration of disease control was 20 weeks. So now we see the results based upon the IHC. The overall response rates in the entire set of patients was just 12%. And in the patients who had IHC 2+, it was also similarly 12%, and the patients with IHC 3+, it was 11%. If we see the disease control rates at 12 weeks, in the entire set of patients, it was 44%. In the patients who had IHC 2+ was 38%, and the patients with IHC 3+ was 56%. Now here we have the forest plot. We see the entire set of patients, all the patients had a exon 19 deletion or a L858R except one which was an exon 18. The EGFR resistance mechanisms T790M was seen in about 5 patients. C797S was another mutation. The non-EGFR mutations, TP53 was the most common which was seen. The other mutations which was seen was the MET amplification or the EGFR amplifications or the cell cycle alterations. Now coming to the adverse events, so nausea was the most common adverse events which was seen in about 6 patients. Vomiting, diarrhea, stomach pain, fatigue, malaise, dry skin, erythema, epistaxis was seen in about 1 to 2 patients. Creatine kinase elevation was seen in 4 patients and pneumonitis in 2 patients. Only 1 patient had a decrease in left ventricular ejection fraction. Grade 2 adverse events were seen in 29% of the patients and grade 3 were seen in 21% of the patients. There was no grade 4, grade 5 adverse event. So to conclude, TREMOS is the first trial which combined TDM1 and osimertinib in EGFR mutated NSCLCs in the patients with HER2 bypass tract resistance. The safety profile is, it's almost identical to the chemocytotoxic chemotherapy, but the problem is the efficacy. There's no actual benefit. The PFS is just 2.7 months. The lead author, Dr. Merrill, said it's kind of disappointing. So with this, it's a kind of a negative trial. We still do not know exactly how to target these patients and how to further go ahead in these patients. Thank you.
Thank you, sir.